Good afternoon and welcome to our webinar, Self-Talk in People with Down Syndrome, presented by the Adult Down Syndrome Center. Our presenter today is Dr. Brian Chicoine, and he is the medical director of the Advocate Medical Group Adult Down Syndrome Center. I see we still have a few people trickling in, so I'm going to go over a housekeeping item and then turn it over to Dr. Chicoine for today's webinar. Next slide, please. This webinar is being recorded, and we will share the recording in our resource library within about a week to 2 weeks of the presentation. We'll also send it in an email to all those who have registered for today's webinar. We will have time for Q&A at the end of the webinar, so please use the button pictured on the screen that says Q&A to submit questions, and feel free to submit them throughout and we will address them at the end. So now I'm going to turn it over to Dr. Chicoine. Thank you again for being here today.
Thank you, Laura. What a pleasure to be here today to talk about a topic that is so important to us here at the Adult Down Syndrome Center, self-talk. And so just want to introduce, for those of you that don't know us, so we work at the Adult Down Syndrome Center in Park Ridge, Illinois, a Chicago suburb. We provide healthcare for adolescents and adults with Down syndrome. And again, we're located in Park Ridge. And we opened in 1992. And since then, we have seen over 6,000 adolescents and adults with Down syndrome. We provide a team approach to try to provide comprehensive, holistic, community-based healthcare services. And just as a reminder, this is information provided for educational purposes only, and is not intended to serve as a substitute for medical, psychiatric, mental health, or behavioral evaluation, diagnosis, or treatment plan by a qualified professional. So certainly this is information you can use for your own education, as well as sharing with a professional if that is something that you would find helpful. So what are we going to talk about today? We're going to start to talk about, we're going to introduce the self-talk and define self-talk. We're going to describe the benefits and function of self-talk, and we're going to discuss what a change in self-talk may indicate. So sometimes self-talk will change. And then we want to explain ways to address these changes in self-talk. And then I want to share some case examples that might further explain self-talk and hopefully that you might be able to relate to and put in perspective some of your questions as well. And again, as Laura mentioned, we will definitely leave plenty of time at the end for questions. So first off, what is self-talk? So it's talking aloud to oneself or an imaginary friend is what we consider self-talk. In and of itself, we think that this is not abnormal, and certainly it is not unique to people with Down syndrome. So we got interested in this many years ago, shortly after the clinic opened in 1992, because so many individuals with Down syndrome were coming to us on antipsychotic medications. And as we pieced it together, it had been discovered by their family and another provider that they were talking to themselves. And the provider had made this diagnosis that these individuals were psychotic at least partly because they were talking to themselves. And we were kind of interested in that. At that time, actually Dr. McGuire and I, our former social worker, both had young children at that time. And we noticed that our children talked to themselves as well, and also had imaginary friends as became clear that some of these individuals that were talking to themselves also had imaginary friends. And so as we began to look at that and we looked at the developmental stage of our patients, that some of these individuals with Down syndrome were similar developmental stage as children who self-talk. And so we surmised that this was a developmental stage appropriate behavior, if you will. And like in children, children will, as they get older and become adults in the non-Down syndrome population, typically they'll internalize that self-talk and not think it more than self-talk it, where many people with Down syndrome would continue to do it aloud. Subsequent to that, articles came out that people involved in sports or strenuous activity will often talk to themselves as a way to coach themselves through. And then as time has gone on, more research has come out that many people without Down syndrome, many people without Down syndrome also talk to themselves. So this is not an unusual behavior at all for any of us, and so this is it's fairly common. The other thing that we have noticed in some of the individuals that we see is not only do they talk to themselves or to an imaginary friend, sometimes they'll talk to an inanimate object such as a doll, and so this can actually be another way that this self-talk manifests. So what are the functions of self-talk? So there are many. It has a lot of uses in the people with Down syndrome and others use for self-talk. One is it's a way to process information. So you come home at the end of a day and you're kind of, I might think through my day and think of what happened and think of the harder times and think of the fun times. And so I'm sort of processing the day. And I will sometimes I actually do it aloud, but oftentimes I'll do that silently. But many of our individuals with Down syndrome that we see will do that aloud. So they will use this self-talk to process information, to process their day, to process what's been going on. It's a way to learn new skills. And so this is a way to kind of work through a problem or work through to develop a new skill. And it's interesting, we see quite a few folks with Down syndrome that will talk to themselves in the third person in this use. So for example, a gentleman with Down syndrome may say, John, referring to himself, John, put the toothpaste on the toothbrush. And he does that. And now rinse it with the water, and he does that. And now brush your teeth for 2 minutes, John. And so this is a way that John is either learning this new skill or practicing and reminding himself to do this skill. It can be a way to problem solve. And so, for example, we might see someone that comes home from work and his mom might say, Joe, we're planning on going to a movie tonight. And Joe stops and thinks and says, boy, this is Wednesday evening. I usually do my aerobics video on Wednesday evenings. So John may go to his room and say to himself, boy, I can go to the movie. That sounds like fun. We don't get to do that very often. Well, and then he may say, no, this is aerobics video night. I should do that. And it's interesting. Sometimes these conversations go back and forth, almost as if two people are talking to each other. You should go to the movie. No, you should stay home and do your video. And so go back and forth. So this can be a way to problem solve as well. And that's another common use of this. It can be a way to cope with challenging situations. It can be a way to soothe oneself. For example, we might have someone that's admitted to the hospital, and I might say to them when they come in, Sally, you're going to be okay. We're going to do these tests. We're going to draw the blood. We're going to get you this medication, and you're going to be okay. And then throughout the hospitalization, you might hear Sally say to herself, this is, you're going to be okay, Sally. It's going to be fine. They're going to take good care of you. And so again, sort of a way to cope with challenging situations. A situation that happened years ago was one of our family medicine residents was rotating through the clinic with me. And she was in the exam room with me, and it was the patient and his mom. And the mom, the conversation sort of moved away from him for a moment, kind of dealing with some more challenging healthcare issues. So I'm talking to the mom, and the resident, family medicine resident, looks over and notices that the young man with Down syndrome is speaking to himself. And she can hear him say, and this was a female resident, and he says, who is this girl? Why is she here in this room? I don't know that I like this situation. So again, this was something new to him, not that he was, the residents are often not with me when I'm seeing patients. And so this was new. And so this was a challenging situation for him. And that's the way that he worked through it. It can be a way to direct one's own behavior. So sometimes we'll hear, sometimes people will talk about themselves or to themselves in the third person. Sometimes not, it varies. but it might be, there are situations that's upsetting to them, and they just remind themselves because they've been reminded that this is not a situation that you should, you would want to yell. And so they might say, don't yell, or they might say, don't hit if sometimes they have a little difficulty controlling their emotions in this type of situation. And it may also be something that people will be able to keep on schedule. And so we might hear someone say, it's 10 o'clock, it's time to go to work. And so again, just a way to kind of direct their behavior in a positive direction. And then it can also be used to counter boredom. Again, we might see this in the office if the discussion sort of moves away from the individual for part of the appointment, where the person might start reciting a movie or repeat a dialogue from them. And so this is just the way that they're bored with the situation, and so they're making the best of it through that sort of aloud reviewing the previous movie they enjoyed or something like that. The other thing we've also seen is that sometimes people will also do this with writing. It's not always talking, but sometimes with writing. Sometimes people will write sentences or words, sometimes even what appears to be sort of nonsensical characters or letters or characters mixed in with letters. So sometimes we also see people will do that as a function. That's it may not be used for all of these things, but we do see certainly some individuals use as a way to cope with the challenging situations and to counter boredom. So if someone is upset about something, they may do that as sort of a relaxation technique. And we've seen that have a lot of individuals that we see that use writing in that fashion. So what about managing self-talk? So first off, again, we think very often self-talk is normal. It's a way that the person is processing information, working through things, and all those things we just talked about. So in and of itself, we don't think that it's abnormal in most situations. So the first thing, as far as managing self-talk, if there's some challenges with the self-talk, first thing is to reassure the individual with Down syndrome that self-talk is okay, that they are not a bad person because they self-talk, they're not unusual, they're not, that this is not something that they should be ashamed of, and really reassure the individual that self-talk is okay. And then the next thing might be that perhaps the situation is that self-talk is disruptive. So certainly talking to oneself loudly in a classroom is not the best use of picking a location to self-talk. So you have to explain sometimes that talking out loud can be disruptive to others in certain situations. So that's not something we would prefer not to be done. So it's not bad in and of itself, and you're not bad for doing it, but in this situation, this is not something that works. So let's provide some guidance on appropriate self-talk. So, we want to identify places where individuals can self-talk. We want to look at it as public versus private in a sense. So in your bedroom at home, designated places at school or work. Sometimes, we have some individuals that just need to self-talk to kind of relax themselves or deal with the stress of school or work, or whatever the case may be. And so maybe building into the day, every couple hours, we're going to have a 5-minute time when this person, gets kind of a break to go to a private place where they can kind of work through the challenges, the stress that they're feeling. Certainly others may go take a cigarette break, where this would be a self-talk break that you can build into the day. You can use visuals that can be used to remind the individual. And this may be something that is done each morning. So if the person's off to work, and we know that talking in a situation where it's disruptive at work has been an issue. And so we're gonna develop a visual that indicates to the individual that here's a place that self-talk is acceptable, and here's a place that is not, and then try to work through that with the individual. And sort of as a reminder what the appropriate places to do self-talk would be. And then it's something that may need to be practiced and reinforced, whether it's with visuals or other, live practice sessions, if you will. We're going to be going to the store, and if you're feeling stressed, here's a way that you can do that without doing the loud self-talk that may be disruptive to others. And then some families have developed what they call a secret sign. And what is meant by that is, so the individual is school, or school is probably not a good example because the family's not there, but sometimes the teacher can do it as well in a conversation with the individual with Down syndrome and their family. But so that if they're starting to do the self-talk in a situation that was agreed upon was not the appropriate place to do it, the teacher or the family or whoever can give sort of a secret sign, and that may be, sort of like a baseball sign, touching the ear or touching the nose or whatever the case, whatever is agreed upon, that can be done. Now, the advantage of a secret sign is that the person, we don't want to embarrass the person. Again, we've talked about how this is normal, is not abnormal, and so we don't want to embarrass them to make kind of point out that this is happening, but we do want to help them to remember to, if they need a little reminder, that this is not the location that we should be doing this. And sometimes it's not about changing the person or redirecting the person. Sometimes it's just informing others. So there are certainly situations where it really is not disruptive. It just is, and someone might say, well, what is this all about? And if we can just educate them, and oh, I get that, so no problem, that's fine, and nothing to worry about, and so that could be helpful, for them to just sort of accept it and understand what's going on there. So sometimes we need to educate those who interact with the person with Down syndrome to appreciate self-talk in the same way that you might, or the person with Down syndrome might. So again, generally, we do not look at self-talk as being an abnormality. Again, sometimes what we would call a social skill. We need to help the individual with Down syndrome learn places where it's okay, or places where it's might be disruptive, and we want to do something different. So in and of itself, we don't see this as a big problem. However, there's the caveat. However, sometimes there is a change in self-talk, and that certainly is something we take note of and want to take a look at and see what that might be about. So, for example, sometimes self-talk will become angry or self-flagellating, where before it was just kind of working through problems or encouraging oneself. Now it's got this anger to it, and this sort of, Johnny, you're stupid, Sarah, you're dumb, Sarah, you don't know how to do anything, and so that becomes concerning. That what is that? Why is that happening? What's that all about? As one family said, some people will develop a maladaptive daydream, which is, I think, a nice term. And really, we're so they develop this self-talk and these imaginary friends and this entire fantasy world the person is in and really prefers to be, and is difficult to get out of that fantasy world or get out of that maladaptive daydreaming. I really like that term. And then the other thing you might see, there's a lot of ways you may see us change, but there's just a few examples. And another one might be that there's less ability to discriminate appropriate places. So again, this is an individual that we've had conversations with. We explain that this is not abnormal in and of itself, and however it can be disruptive in certain situations. And so the person is doing well in school, has his self-talk breaks or whatever, and is able to do it at the end of the day, and doing very well with that. And then suddenly, kind of without a clear indication, is starting to talk very loud to himself in the classroom. And sometimes, again, we'll see some of that anger or self-flagellating or just becoming lost in this fantasy world. And so that certainly is something to take note of. And then, what are the potential, why is that happening? And so what are some of those potential causes? It might be stress. Someone might be under stress for a reason. It could be that, there's someone, again, we'll use the school example, where there's maybe someone giving them a hard time about something. Maybe there's a work, assignment or something that is challenging, and the person is having a hard time sorting through it and is feeling stress from that. It may be, that there's an upcoming move, or there's somebody in the house, a sibling is going away to work or school or moving out of the house, or whatever the case may be. So lots of reasons that things can be stressful. And those are more social. We think of those more social stressors, but there can be pain or physical ailment. Something is the person is feeling poorly and is not having a hard time explaining that that this is happening, and so they'll start to talk to themselves and try to figure this out in a way that works for them. Um, to try to sort through this discomfort. Sometimes it's associated with mental illness, with anxiety or depression or other mental illnesses or even psychoses, where someone has developed these mental health problems, and you see a significant change in self-talk. Certainly, we see a change in self-talk in some of the individuals we see with dementia or Alzheimer's disease. And sometimes you'll see an increase, sometimes you'll see a decrease with self-talk over time with the dementia. Some people are using it as a communication device. We'll talk about in a minute here that sometimes individuals with Down syndrome actually speak more clearly when they are self-talking. And so it may be hard for them to get their point across with just talking to another individual. And so they're talking out loud to themselves, maybe in a way sort of almost hoping someone will hear them and help them out. And it may just be a communication of this stress or of this pain or whatever, that this person is just trying to share that something is not right. It may be a sensory issue. If they've had a change in their sensory perception, or if there's something going on in their environment that is insulting one of their senses in a sense, that may be a stressor in and of itself as well. And that may be a cause for a change in self-talk. And then there may be environmental issues. What is going on in the environment? It could be something as simple as the temperature of the environment. It could be someone in the environment. It could be, just a change in the environment. The move we talked about before. So lots of things in the environment that can the noise, or whatever the case may be. Lots of things in the environment that can be irritating, and particularly if the person has a difficult time sharing those concerns, verbally from one person to another, they may use self-talk to try to sort through them, as we talked about earlier, as far as some of the reasons that self-talk is used. So I'm going to just give a few cases now, and I'll just tell you that these cases are really a blend of multiple people, that they're really not about any one individual. So for privacy's sake, and so this is not, I'm not really speaking about any one individual in these cases, but use multiple individuals to sort of make cases that would give a good point of what we've seen in the individuals with self-talk. So let's talk about a 25-year-old woman who self-talks in her room every day after work. And she comes home from work each night. She talks with her parents and then goes to her room to talk through her day. And the self-talk is pretty similar each day. And again, as I mentioned, it's often easier to understand someone when they are self-talking than when they're just talking to somebody else. And so that can be something that we'll talk about here in a second, why that can be important. Because it can be a way to learn what is going on by listening. Occasionally her self-talk will be more animated, and the parents will listen at the door on those days to try to figure out what's going on. I should add that many people with Down syndrome see this self-talk as private, and so this out of a courtesy for their privacy and as a respect for their privacy, it might be a good idea to discuss how she feels about you listening outside the door, and have a conversation with her. We hear that you're struggling, and sometimes it's helpful for us to hear that. And we know sometimes you have a hard time telling us, but we know that you talk about it in your self-talk. And would it be okay if we listen if we're concerned, so that we can then talk through that with you to sort through the problem. And so again, if there's been a stressful situation at work, that gives the family an opportunity to understand better and then walk or talk through it with the individual, and then perhaps to do a stress reducing activity that evening that might not be part of the usual routine, but on a challenging day, might be something that is helpful. And let's go to case 2. So this is a 33-year-old man. He self-talks in his room every day after work. And self-talk is similar each day, so similar to the individual, the woman in case 1. But in the last 6 months, self-talk has become much more agitated. There's less appreciation for socially appropriate places for self-talk, as we mentioned a bit ago. Now he's doing it in places that previously he understood were challenging for others when he did that, when he self-talked. But now he's pretty indiscriminate about self-talking wherever, whether it's bothering somebody else or not. And then it begins to sound more hallucinatory or psychotic. So how do you know when it's hallucinatory or psychotic? This is not always easy to tell. There's kind of a gray area oftentimes in this with self-talk and imaginary friends. But some of the things that we look for, if it's less redirectable. So if the person typically is self-talking, but now it's time to go to work or go to wherever, you can say, Bill, it's time to go. Can you get your coat on and get in the car or whatever? And he's able to stop the self-talk and then move on to the next activity. But if that becomes less and less redirectable, that can sometimes be concerning. Not always, but can be concerning. Perhaps the person is spending more and more time, as the one individual that described the daydreaming, said that the person just sort of gets lost in this self-talk and becomes so involved in these imaginary friends or these this sort of whole world that sometimes people will make, and that sometimes can be concerning. Not always, but again, that can be concerning. And oftentimes it's more agitated or more, like I mentioned, self-flagellating, where there's anger. And oftentimes the imaginary friends in those situations upset the individual, where many times in self-talk and imaginary friends, it's all pretty positive. It's, these are friends I talk to that I like and they like me. But sometimes in these hallucinatory or psychotic situations, these friends are telling people to do things that they don't want to do. They're making them sad or angry or anxious. And so again, that'd be another thing to kind of look for that might be a warning sign. And so particularly when and then it also often becomes less functional, where before the person could work through a problem, could learn new skills, et cetera, we talked about before. And now it just becomes something that is just sort of just lost this and just anger and not really seeming to have any benefit at this point in the individual's life. And that again can be a concerning thing. And again, where the imaginary friends are telling them negative things, it can also be a sign that something may be awry, particularly if that's a change. And this individual, this 33-year-old man, as we worked through this with him and his family, we did note that he had gained some weight in the last year or two, and he had begun to snore, and they had begun to notice some pauses in his breathing. And so he was sent for an evaluation for sleep apnea, and he was treated for sleep apnea, and this all basically went away. His self-talk returned to its previous level of sort of the learning things and working through his day, and this hallucinatory or psychotic-like piece of it, the anger and the imaginary friends telling him negative things, all resolved, and he basically went back to his baseline with treating sleep apnea. So very important, again, just as a reminder, we talked about there can be some physical things that contribute to self-talk, and certainly sleep apnea is one of the things that's common in people with Down syndrome, and certainly can cause changes in brain function and end up contributing to changes in self-talk. So let's talk about a third case. Excuse me. So our third case we're going to talk about today is a 17-year-old girl with Down syndrome. And during COVID-19, she's been staying at home and going to school virtually, as many people have, as there was less opportunity to go to school. Of course, that's improving now, but that certainly was an issue over the last year and a half or so. And the family noticed that she's progressively talking to herself more and more. There's beginning more agitation. She's not sleeping as well. She has a decreased appetite. She has a loss of interest in previously enjoyed activity. So all those things can be associated with depression, which we ultimately diagnosed her with. The sleeping change, the appetite change, the change in the self-talk, even the agitation, and then the loss of interest in previously enjoyed activity are all kind of hallmark symptoms of depression. So we evaluated for her, and then we found no physical conditions, no sleep apnea, no thyroid problems, no celiac or B12 or other conditions that likely had been contributing to this. So we diagnosed her with depression. Again, this is during COVID. So initially we tried some online therapy, but she really wasn't able to participate very well in that. So then Dr. Frank, our occupational therapist, worked with her and worked on some relaxation and sensory techniques. And they had some improvement in the situation, but it was not completely resolved. Ultimately, she did end up needing to be treated with an antidepressant, and over the next several months, she improved and ultimately returned back to her baseline. So again, certainly looking for, again, although in and of itself, just as a reminder, self-talk is not, we don't consider it, necessarily a bad thing in and of itself or a concern in and of itself. Certainly these changes can be things, particularly when they're associated with some of these other symptoms, are definitely things we want to take a look at and see if there's something else going on. Sorry. Fourth case. So this is I should mention, go back and mention on this young lady. While she improved significantly with the treatment we outlined there, she didn't actually completely get better back to her baseline until she was able to return back to school. So she needed that routine and structure that she was so used to in order to return back to her baseline. So she had a significant improvement, but not really 100% until she was able to get back to school. So a fourth case. So this is a 36-year-old man. He's, again, not able to work due to COVID during the pandemic. He did not have COVID, but he had, the change in his routine and schedule and whatnot due to COVID, not able to work. And over the course of several months, he became really severely withdrawn, a marked increase in self-talk. We evaluated him, again, looking for a variety of potential causes for self-talk. We assessed him, and he was treated and diagnosed and treated for hypothyroidism. But unfortunately, he had a progression of symptoms. We diagnosed him with depression and started him on sertraline, which is an antidepressant. So now he's on thyroid medication plus sertraline for this, as well as trying to do counseling and sensory and relaxation techniques we talked about before. And unfortunately, he had further worsening of the symptoms. Got to the point really where we were not able, the family was not able to redirect him. He just became more and more focused inward, more and more focused on his self-talk, more and more focused on his, as the family described, being lost in his own world. And they were noticing this intense, agitated self-talk with expression of lots of anger and these intense conversations with imaginary friends. So as we continued to follow him and monitor him, we diagnosed him with depression with psychotic features. We should note that these conversations with family, his typical conversation with the family dwindled to almost nothing. And conversations were only with these friends. So in addition to the thyroid medication and the sertraline, we ended up adding risperidone, which is an Sorry, not COVID, just a dry throat. It's dry in here today. So I added a risperidone, which is an antipsychotic, and noticed a nice reduction in the symptoms. And again, the symptoms did not completely resolve until he could return to work. And the other thing to look for, in addition, for when you're looking at whether this may have a psychotic component to it, would be, are there other features of hallucinatory features or other psychotic-like features that might be involved? So sometimes as people get, kind of get lost in this world, occasionally we, might have someone that's, one person was complaining that they were seeing bats flying through their room, or seeing animals in their room that weren't there, of course. So those would be other things to check on to see if there are other symptoms of psychosis that are occurring. Excuse me. Now let's go to the a 29-year-old man. He was ended up being brought to us because there was concern about having a psychotic disorder. So what had been happening is they had noticed a significant increase in self-talk. He was isolating himself, and he was refusing to collect carts at the grocery store where he worked. And that was part of his job at the grocery store. And he had been diagnosed with psychosis by another provider. And the family brought him to us for a second opinion. Again, there's a gentleman that talked more clearly when he was self-talking. So the mom ended up listening outside the door. And she heard him say on multiple occasions, "No one is helping me up." And she didn't really know what that meant. And so we referred him for counseling and also reviewed it with the store manager. And between the counseling with the gentleman with Down syndrome and with the talking with the store manager, it became clear that the individual with Down syndrome here had been struck by a car in the store parking lot. Unfortunately, the driver did not stop, and no one helped him up, and thus probably this where he's saying no one is helping me up. And on top of that, he was out in the parking lot a while because he had been hit by a car. The boss, upon returning to the store, the boss had become angry with him due to him being so slow to return to the store. Of course, not knowing that he had been hit by a car. And so, that just was, too much for him. That was just, between being hit and no one helping him and the boss getting mad, that was just all very disturbing to him. And so this was all really not clear for a while, but a customer who was kind of interesting later reported, had come back to the store and had reported, I did see that, he's not acting quite himself. And I did see him get hit by a car a while back in the parking lot. So that was reported. So then it began to all kind of fall together. As we worked through this with he and his family, it really did not appear to be psychotic. But he did certainly have this fear of the parking lot. So he underwent counseling, continued to undergo counseling. And despite the counseling, his fear of the parking lot persisted. And so although he, most of the rest of the symptoms had significantly improved with the counseling, again, did not end up needing medication, they did have to modify his job so that getting the carts was not part of his job. And so he actually, otherwise, other than not getting carts as part of his job, he ended up pretty much resuming his previous level of function. Now, he did periodically need some reassurance that people care for him if he expresses fears. So, he still had this kind of a little bit of this lingering thing that, if something happens and I'm afraid that no one's going to help me. So at times he would need reassurance that people do care for him if he expresses these fears and they want to help him. So what are some takeaway points on this? First off is that self-talk is usually normal and quite functional. So it really does help a lot of individuals function very well and in some ways sort of outshine their cognitive abilities, if you will, because they're able to use this self-talk to guide themselves and coach themselves uh, through doing tasks and doing working their way through things. So it's usually normal and functional. It can obviously be disruptive in certain situations, and it may require social skills training. Again, learning whether this is private or public space. Where's a place where this is okay to do? Where's a place maybe better not to do, so as not to interfere with what others are trying to do. And it may need to be explained to others. This is a common thing in people with Down syndrome. If it's not really bothering anybody, probably not anything you really need to address or worry about. And certainly don't make the individual feel bad about it. Because again, this is just part and parcel to who many of these individuals are. And there's a common thing that they do. And so we don't want to make the person feel bad. We just want to help them just do it in appropriate settings. And again, if it's not bothering anybody, let it ride. Certainly, so in and of itself, we're not typically concerned. In a lot of ways, I say that, just as I might go home and think through my day, I would not expect someone to say, don't think through your day. I would not, expect an individual with Down syndrome not to talk through his day if that's what he or she needs to do. However, that there can be a change, and that can change for a variety of reasons or stressors, and that's really the key to looking to see if you can find why that has occurred, and particularly not to assume that it's psychotic upfront in all cases. As we talked about, certainly there are situations, there are individuals that do develop a psychotic nature to this and need some additional treatment, but many people that's not the case, and so it does not need that treatment. Many people doesn't need to be treated at all, but certainly if there is that change, sometimes there may be something that needs to be done to try to address that. And again, there can be lots of reasons for this. It really does have to, puts the onus on us to kind of look and see what may be happening. And like the gentleman that got hit in the parking lot, there may be things that we just don't know. I like to say that, we probably often miss the diagnosis of, where someone has been injured or something, and we don't know why they're having that change, and post-traumatic stress. We don't know why they're, why that happened, and so we sort of miss. We don't know what the trauma is, so we don't appreciate that this is a post-trauma stress disorder, and so we may not understand that because we don't know what the stressor was. And again, I always like to say about stress, what I find stressful may not be the same that what a person with Down syndrome finds stressful, or vice versa. But just because I don't find it stressful doesn't mean that it's not stressful. And so certainly things that we may not appreciate, as that you and I may not find stressful, the person with Down syndrome might, and that it doesn't matter if I find it stressful or not. If he or she does, that's something we need to note. And then treatment depends on a variety of factors. It is certainly the severity and what the underlying diagnosis appears to be, and then what a response to other treatments. And so if a person responds well to one treatment, that may be all we need, but if not, then we may need to do some additional things. And typically we do try to, if there is a concern that there's an underlying problem, we certainly want to address the underlying problem if at all possible. And then if it does seem to be associated with a mental health problem, we want to try to use the non-pharmacological treatments, if at all possible, first, whether they be stress reduction, whether it be counseling, art therapy, or whatever the case may be. But sometimes people do not respond to that, and so medications do become necessary. On the other hand, sometimes people are having a hard time, individual with Down syndrome having a hard time responding to the art therapy or the counseling or whatever, because they're still, this is so intense for them that medications can be used to reduce the intensity, but then allow them to be more receptive, responsive to these other therapies and efforts of stress reduction, et cetera. So sometimes we can get away without any medication. Sometimes we do need to add a medication, and sometimes the medications will really augment the ability to participate in those other initial efforts that are done without medications. We have some information on our resource library about articles on self-talk. We have a number of mental health resources that are available on our resource library, and then a number of social skills resources that a lot of ways to help guide people into, with appropriate, skills that allow them to participate in society and to not do it, not self-talk, for example, when it's disruptive, for example. And this is these slides were made available, but this is our resource library. We have pretty much basically every day Laura posts something on our Facebook page, and much of it is informational, like self-talk or the groove or common health problems or whatever the case may be. So that's certainly something that a number of people have found beneficial, and so I encourage you to take a look at that. And then lastly, we have a email newsletter. It comes out once or twice a month. That again will highlight some of the information that we're either have added to our resource library, or we kind of a summary of what some of the things that are on Facebook that you can subscribe to and get on a regular basis. Even if you're not local here with us, in our area. Much of what we put in on the Facebook page and email newsletter is not sort of local news. It's general information about people with Down syndrome and their health that anyone hopefully would find helpful. So I did want to leave. We often get lots of questions about self-talk, so I did want to leave a fair amount of time so that we can address any of the questions that people may have.
Thank you so much, Dr. Chicoine. We have received several questions. Please feel free to submit them using the Q&A button. And as a reminder, I mentioned earlier that we are recording this presentation, and we will send a link to the recording as well as a link to these slides within a week of this presentation. So I'm going to go ahead and dive into our questions here. So we received a question: is it fair to say that you shouldn't interrupt your loved one when he or she is talking?
Yeah, I think when individuals will see this as a conversation, and sometimes even people. Our former social worker tells the story of a gentleman that was talking to himself in his room, and a family member knocked on the door and came in and said, "Who are you talking to?" And the gentleman with Down syndrome looked at the family member and sort of a quizzical look and said, "Myself. Who do you think?" So really, this is like a conversation, and I think just social norms would be we don't interrupt people, and so I think in general I would say out of respect and courtesy, I wouldn't interrupt. Certainly if there are you're hearing concerning things, it may not be the time to right when they're saying it, maybe time when they're finished to pause and have that conversation. But I would say generally, again, if it's in a socially in a setting where it's socially challenging, I think that's certainly something that could be interrupted from that standpoint, or more than perhaps more better term instead of interrupt is to redirect to a different location, perhaps. And again, that's where some families will use that secret sign.
Thank you. Is it considered self-talk when an individual speaks about a fictional character or refers to themselves as the character? Should there be concern if this goes on for several months? The individual might change the character at times too.
Yeah, I think that's a great question. And I think, sometimes that it can end up being one of those gray areas. But for most people, this is not concerning in and of itself. We do see individuals that will take on a different persona. And again, if we go back to our original thoughts on self-talk, that this was a developmental stage appropriate behavior, that's something certainly children will do as well. If the individual is, I'm a character from Frozen or something, and But when it's time to go to work, the person goes to work, or go to school, the person goes to school. If we're going to go play tennis, he goes and plays tennis, or he gets his chores done, whatever. Certainly that would be concerning. If this becomes more intense and not able to be redirected out of it, then that would be more concerning. I wouldn't say that I would be cautious just to say that I'm not suggesting we redirect the person out of it every time they do it. I think that this can, again, be self-entertainment. And so I think that in a lot of cases, this is okay in and of itself. Again, I think there's socially appropriate settings that I think might need to be considered. And again, if the issues we talked about with the psychotic features of whether there seems to be psychotic, I think that would be something to consider. But a lot of people with Down syndrome do this and otherwise seem to, not otherwise, but in addition, seem to be very healthy physically and mentally, otherwise, working, going to school, participating in family activities, exercising, do all the other things, but also do this. And so this is just part and parcel to who they are. Other people might get really lost in watching Netflix and almost, put themselves into Netflix when they're binge watching Netflix. And so I think that people with Down syndrome often don't need Netflix to do this. They can do it. They can do it without having something being shown on a screen. They can do it individually like that. So again, I think you really want to look at what else is going on and what are the other findings and whether that's something to be concerned about.
Thank you. This next question says, for individuals who may be in the process of developing Alzheimer's disease, is there a change in self-talk?
Yeah, a good question about Alzheimer's disease and self-talk. So there certainly can be a change in self-talk. Sometimes people will start to do it more earlier on in the disease as they're finding this stressful. I think we definitely have individuals with Down syndrome who are aware that there are changes going on within them. They're appreciating, as one individual said, my brain hurts and my brain doesn't work. Some people with Down syndrome certainly notice that that something is happening. They may not be able to say I think I have Alzheimer's disease, but they appreciate that something is not right, and that can be very stressful to them. And so certainly in that situation, we may see an increase in self-talk. Unfortunately, as the cognitive impairment with Alzheimer's disease progresses, we'll typically see people not only talk less to others, but also talk less out loud. And ultimately, most people with Down syndrome and Alzheimer's disease, it'll go away completely as the disease progresses.
Thank you. If a person is using self-talk to process issues or manage anxiety, is it appropriate to encourage them to try different ways of doing this, or should they be left to continue?
Well, I think it's okay to give them, an armamentarium. In fact, this might be a good place. Dr. Frank is waiting in the wings, and she has a lot of ways. We talked about this with the groove as well. When we gave the presentation a while back, Dr. Frank has a lot of ways that to try to give people a multitude of strategies to deal with things. Dr. Frank, do you want to just jump in maybe a little bit?
Sure, absolutely. Although, Laura, will you repeat the question again? I apologize. I was looking at the other questions.
Not at all. If a person is using self-talk to process issues or manage anxiety, is it appropriate to encourage them to try different ways of doing this, or should they be left to continue?
No, absolutely. So some of those other strategies might just be some stress relief strategies. So you'll see in our resource library, we have a variety of resources about stress management. So whether it's just taking deep breaths or ways to calm your thoughts or calm your body, strategies like listening to music or journaling. There's a whole video where our friend Cindy talks about what she likes to do in order to manage her stress. Sometimes sensory strategies can also be helpful because we might not actually have sensory processing deficits, But there's times when our sensory system, the messages aren't being sent properly from the brain to where they need to go in the body. And it might feel like fireworks are going off in our body or ants are crawling on our skin. And that's sort of what anxiety feels like as well. And so if we do sensory strategies to help calm or relax our body, we might be more open to other strategies that also might decrease self-talk a little bit. So some of the sensory strategies I like to try here are called proprioceptive input. So our proprioceptive system is about our awareness of our body. And so when we give proprioceptive input, we give input into our muscles and joints. So this is any kind of pushing or pulling activity, any kind of weighted strategy. So chores are a great way to naturally get proprioceptive input, exercise or any kind of physical activity. Then there's things like weighted blankets or weighted lap pads, sometimes vibration, even though that can also be a little bit of a vestibular input, can be good input into muscles and joints. And we have some resources also on sensory in our resource library to talk more about proprioceptive input, joint compression, and some equipment recommendations that are more affordable. Because oftentimes, if you look in therapy catalogs, the strategies are just super expensive.
So yes, I think I would go back to what I said before, but I wouldn't make the person feel bad about the self-talk or that the self-talk is bad in and of itself, but to arm the person with a variety of techniques that Dr. Frank just talked about, where one might be appropriate in one setting and one might be more appropriate in another, so that the person has a lot of ways that they can deal with stress. And I think that's good for all of us to have, multiple arrows in our quiver, so to speak, to deal with the daily stress of life.
Thank you. We have received several questions about the maladaptive daydreaming. Would you mind reiterating some of the strategies that you can use to help an individual who may be doing that maladaptive daydreaming?
Yeah, let me see if I can go back. No, I thought we had this thing on there. Oh, here we go. I think in general, the first thing is again, try to assess, is this a problem? Is this sort of just a natural, way that the person is working through their day? But certainly when it becomes, this maladaptive daydreaming, you want to go and use all those strategies. In this case, sometimes maybe not so much reassuring the individual that it's okay. Maybe the person's too deep into this, but certainly want to make them not feel bad about themselves that they're doing this. That this may be something that they're doing in response to something, and so we want to be careful not to make the person feel bad. And again, there may be ways to explain that the self-talk can be disruptive. And then we want to again provide guidance, public versus private, and then visuals can be very helpful. And maybe Dr. Frank can talk about that in a second. And then it's something you may want to practice and reinforce. And again, I think if this becomes deeper and deeper, then we really, that's a change. And so we really do want to go back and look, is there something else going on? Is there a physical change? Is there a social change? Is there a psychological change that is contributing to this? As Dr. Frank just went through, do they need some relaxation techniques, some sensory strategies? Are there other ways to help them to deal with this stress? If that's in fact what's going on. And then if it just becomes very obvious that the person is just so lost in this, it may be that it's reasonable to consider, particularly if you see other forms of hallucinatory or psychotic behavior, it may be time to think about whether something additional needs to be done with the medication. Dr. Frank, do you want to talk any about visuals at all?
Absolutely. So when we think about visual supports, oftentimes people automatically think about pictures, but visuals come in a variety of forms. But the important thing to remember is no matter what the format is, it's why we use them. So visuals can be used to share and manage expectations or provide reminders, teach new skills, help facilitate understanding of a challenging topic. And oftentimes with stress or anxiety, these visuals can be helpful because they're going to help share guidelines or expectations. And then the person with Down syndrome is going to understand what is required of them or expected of them, and then they can get through their day better. And it might just naturally decrease their stress or anxiety, whether it's going to a new environment, starting a new routine, anything that might be a change in their routine. So they have to go to the doctor's office that day. So maybe their self-talk starts in the morning because they have stress and anxiety about what might happen at the doctor's office. Are they going to have to get a shot or a blood draw? Is it just, someone look in their ears? These things that might be stressful events for them. And so if we can help prepare them for that beforehand using visuals, it might be make it a little bit more successful to help manage the self-talk.
And then you can use those visuals as well for like schedules. So we're going to set aside 1 to 2 o'clock, and you can go do your daydreaming if you will, or build it into the day. But at 2 o'clock, we're going to go to the Y to exercise, or we're going to go see grandma, or whatever the case may be, and then see if that helps. Put some control over it, not control as much as some limitations on it. It's a better word, and so that again, so that the person is able to not get stuck in it, but is able to participate in other life activities.
Well, and then you can also use a timer or some kind of timer as a visual as well to, you can talk for 10 minutes. When the timer goes off, your self-talk is done if you're giving them that built-in time for some self-talk.
Thank you. We've received a couple questions that indicate that some of the causes that you mentioned for a change in self-talk have been ruled out. So they're on an antidepressant, they've checked sleep, they've checked thyroid, hearing. I'm going to put you on the spot, but are there some less common reasons why someone might have a change in self-talk?
That's individual per person, but I think that in a sense, any stressor, physical or mental or social, can ultimately cause a person to self-talk. So there's a wide variety of things, and so it really does. Like the gentleman with the carts, that took a while to sort through because it wasn't initially clear what the cause was. I like to think of myself to some degree every morning as I get ready to come to work that, I need to be a detective today to go searching for what those causes might be that are contributing to these changes. They're really, I would encourage, first I would look for the common things commonly. And so we have some information on our resource library about common medical conditions. So that would be something to take a look at. We also have some information on common mental health conditions, and those would be things to consider. And then looking at a wide variety of social situations. I think it's very common social stressors. Certainly in the last year and a half, the sudden change in schedules, the loss of routine, that has been a huge stressor. So trying to develop some routines, some new routines, to develop, some activities that the person finds interesting, entertaining, whatever, educational. All those are important. And then conversely, now that we're seeing people begin to go back to school or work or whatever, a lot of times we might just assume, well, they're going back to what they love. This should just be fine. But a lot of people are finding that stressful too. They kind of got into a new routine, staying home, or having mom or dad home, or having a sibling home, or whatever the case may be. And now that's changing again. So even in a sense, even good change is change. And so that may be something that you have to take a look at. So again, I think, as Dr. Frank talked about, visuals, schedules, timers when need be, all those things can be, things to try to help, redirect, a person back to their usual self.
Thank you. I put in the chat a couple links. I put a link to a webinar that Dr. Chicoine gave on common health conditions in adults with Down syndrome. And I also put a link to all of our COVID-19 resources. So those might be of interest as well. This question says, so someone walking into their room and saying, "I'm back," and talking a lot to another imaginary person or group is okay.
I think in and of itself it is, generally. I think if there's no other real concerns, that's for a lot of our folks developmentally, that's a very reasonable thing.
And also, if someone recites movies a lot.
Yeah, I think as well that two things with that. One is a lot of folks with Down syndrome have incredible visual memories, and so they're really able to do that, which is so amazing. They're almost like they're able to flip a switch and play the movie as they talk about it. So that's pretty amazing in and of itself. But again, it's relaxation. It's fun. It's entertainment. So just like someone else might go flip on the television, or someone else may do something else to relax. That's maybe just what that individual is doing. Again, the intensity, the ability to redirect. Again, I'm not suggesting we should redirect. But if the person is doing it, and then we know that at 7 o'clock we're going to church or whatever, then and the person's no longer able to do that because they're so doing this so intently or intensely. That certainly is something to take note of. But in and of itself, I would generally not consider that a problem. Unless it's a significant change. That wouldn't be the other thing to think about. If there's a significant change, would be the other thing to think about.
Okay. If my son is talking to himself and it doesn't seem positive, should I try to pull him out of it? And if so, what's the best way?
If it goes on and on, I would probably try to pull him out of it. Yes. If it just seems like it's becoming more and more dysfunctional. But I think sometimes if it looks like it's going to be self-limited in time, the time to do that, like we talked about before, would be to wait till he's finished and then try to sort out with him what may be bothering, if there's something bothering him. And so that, and again, if it's something that you can hear, if you're in earshot and can hear, you might pick up something that is, so if you stop them, you may miss, no one helped me get up kind of statement that one family found or heard. You may miss that if you prematurely stop the conversation. And so if you hear that, that could guide you on how to help them through it. So not so much looking to end the self-talk as we are to look for what is the reason behind it, and then address that, and then see if the self-talk doesn't more naturally go back to its previous level.
Thank you. If there is if there is a mental health issue like schizophrenia in the family, is there a higher incidence of the person with Down syndrome having issues?
That's a great question, and I don't think we have an answer to that. I think, for many conditions in people with Down syndrome, I don't think we really have a handle on which plays a bigger role, the genetics of Down syndrome or the genetics of the family. I think very likely both contribute. I would not be surprised if ultimately people with Down syndrome have more psychoses in families where there is a history of an individual with psychoses, but I can't say that for sure. So I would not be surprised if that's the case, but I don't know for sure that's the case.
Thank you. We have received some questions about the impact of COVID, not necessarily only on self-talk, but just on all aspects of life. I'm going to put in a quick plug. Dr. Chicoine is going to be giving, Dr. Chicoine and Dr. Frank are going to be giving a webinar next week with the Down Syndrome Association of Minnesota on mental health and the COVID-19 pandemic. I'm going to locate that link and put it in the chat. So if you're interested in registering for that, some of those questions will be addressed then.
So I can go ahead and jump in here. So I think that one of the challenges with COVID is that, and you'll see, we have a sort of a delightfully challenging slide that we will show in that next webinar that shows that really the multitude of stressors that are out there during the pandemic. It's the change in the routine. It's family members that are sick. It's being sick yourself. It's being in the hospital. It's a loss of routine. It's a loss of school. It's the list goes on and on. It's mourning, family members who have passed away or friends who have passed away. So really, there's so many unfortunate options or choices or whatever stressors that are all sort of going on simultaneously. So in and of itself, I don't think COVID has been, so incredibly unique that, none of those things are things we haven't seen before. It just, I think the challenge with them is that there's so many of them going on simultaneously in so many people's lives. And so I think that's been particularly problematic. I did see one person had asked about, that the pandemic has been, particularly challenging for people with Down syndrome and or anyone with a disability. And I would say that's certainly true in our practice. We've seen a number of folks kind of pretty much struggle with this, and this has been a lot to deal with. But again, I think we have a lot of information. We'll talk about it next week on that other webinar about ways to promote mental health, and we have a lot of information on promoting mental health on our website. Just so there, in a sense, there's nothing that we would recommend for promoting mental health in general is not also correct to at least some degree for people during COVID. So all those mental health promotion strategies can be used during COVID.
Thank you. This question says, you mentioned flip the switch. We see that a lot as it relates to behavior, and then the self-talk also changes dramatically, up to and including cursing. I think you just answered my question, but should we ignore the bad language and just wait for the switch to flip again? Location, certainly, probably in the middle of church, probably not the best place to let that go on too long. But I think, location is, or the setting is certainly important. But again, I think, not so much the self-talk in and of itself or the language in and of itself, but what is the reason for it? Why is that a problem? Why are we seeing this? Those are the things we'd want to do. And then again, trying to help the individual express that. And again, you might hear something in the self-talk that kind of gives you some clues as to what's going on. Thank you so much. Well, we are running down to our last minute here. And so we will be sending out, as I said, the recording, the link to the slides, as well as a link to a feedback survey. And we would appreciate your time filling that out. We're getting ready for our 2022 session for health education webinars, and we would love to host webinars that you are interested in and you have questions on. So please do fill that out. We would appreciate that. Thank you to Dr. Chicoine for presenting today, and Dr. Frank for chiming in with her feedback on these questions. And thank you all for joining us today.
Thank you very much.